Welcome everybody to Probing the Literature. This is our June 2023 edition on procedures and procedural IVs. We are very happy to welcome Dr. Lindsay Taylor on this session. I just want to go over some of the ground rules real quick. Overall, the schedule is going to go with the presentation from the author with discussion intermingled. As you have questions, feel free to just either raise your hand or pipe up as you see fit. Around 2:25, 2:30, we're going to break up into our small groups and review the second article. We'll reconvene around 2:50, have summary remarks and group discussion. And then at 3 o'clock, depending on if you want to stay for the methods consult, that'll be the end of the first half of the session. I do encourage people to get involved with the methods consult, especially if you're going to become a new fellow. We can start reviewing some of your research ideas and research projects, kind of get you started on all that. All right, so the other thing I wanted to make sure is that make sure you're muted, make sure your camera is on, and then if you can, change your screen name to indicate your name. And then I'm actually going to change my own real quick, apologize. You're kind of like faculty level, if you're a fellow, faculty, and then your location. For me, it's like University of Buffalo. So without further ado, I am going to release the stage to Dr. Taylor. Thank you again for coming.
Yeah, my pleasure. I'll share my screen. All right, you guys can see that okay? Okay, as many of you guys have been on some of my chats before, you'll know I've disclosed that my stats is not the strength of my work, but I feel like I can always come up with a good idea. And so it's always good to have good idea makers and then just know who your stats people are. So if you're more like me, then you'll feel comfortable with my study. It's not very high intense stats, but I thought it was a good idea. So just ask any questions throughout. Happy to answer throughout and go from there. So this article that we're talking about today is the novel approach to ultrasound-guided thoracostomy. And I titled it No Gut, if you kind of arrange the letters a little bit. And so as the title implies, we're using the ultrasound to help identify the zone of safety for chest tube insertion and specifically not in the gut. And so the inspiration for me came from our obesity epidemic. And I did my residency training in Detroit. And so, you know, if you guys are familiar, obviously, I think anywhere we are right now, this is the case, but the Detroit normal was the colloquial term for somebody who was just morbidly obese. And so, you know, with this in mind, the technique and the research has come as providers face these challenges to try to care for these critically ill patients, and we lose our landmarks. And so that makes it difficult. So traditional landmark thoracostomy technique has known to have a complication rate of 30%, and chest tube placement's not getting any easier when you can't palpate for the proper landmarks that we're taught with ATLS. And so while earlier data suggests that ultrasound can be a beneficial tool for identifying the correct thoracostomy site placement, we still have limited clinical trials on it. And so we had created a prospective randomized study to assess ultrasound guidance to improve the thoracostomy site identification in patients and compared it to traditional landmark techniques. It started in 2018. We published this paper on the technique, and I'll get into the technique in just a second. And this was on healthy, voluntold med students with normal anatomy, normal BMI less than 25. And so what we did was just practicing how to use ultrasound to identify the diaphragm and the appropriate intercostal space. The conclusion of this study, and like I mentioned, the limitations of being that normal body, normal anatomy, was that it did improve some of our novice learners on how to get the proper identification site. But as I mentioned, it didn't include people with higher intra-abdominal pressure, such as pregnancy, a potential for a paralyzed hemidiaphragm, a ruptured diaphragm, so things that we could potentially see in our everyday population. And so here's the technique. If you, I don't know if everybody's institution, but ours is, I always refer to it as ABEM General. We've got every service known to man And our trauma service likes to pan scan everybody. So everybody gets a pan scan that comes to the door, and they get an EFAST, whether it was penetrating, blunt, hemodynamically stable or unstable. That's just kind of the way our system has kind of worked. And so that being said, if you start with your EFAST position, either right or left upper quadrant, and slide cephalad, this is what you'll see. And so this is the first study and the second, so I'll kind of combine the two, but you'll see identify your diaphragm, you'll identify that rib, and then your intercostal space. And in the next slide, if you keep your eyes on the near field of the slide, you'll see how we just kind of advance towards the cephalad. So if you're looking at the ultrasound image on the right, you'll see the kind of 1 space, 2 space, 3 space. The initial space right next to the liver, we called no man's land. You definitely don't want to be putting any kind of instrumentation through that zone, that intercostal space. And then we allowed for excursion of the diaphragm by going at least 2 more spaces above that. In this particular image on the left, this we had used in the first study to apply a invisible ink marker to the med student. And so we pre-identified where we thought, the 4th, 5th intercostal space was, and then either using landmark or ultrasound, the residents went through their student and would point to where they would probably put their, make their cut at least. And so that was the first study. In the second study, what changed was now our patient population is applied to, as I mentioned, our ABEM general. We decided every low level trauma that came in, so we call them level 2, essentially, that are stable, that are not needing a chest tube necessarily, that we weren't rushing to the OR or rushing to the CAT scan. These patients, we basically standardized our residents to, they learned both, we had to reteach the landmark technique, basically ATLS guidelines, as well as we taught them this ultrasound technique with moving 3 rib spaces. We randomized the residents to either the traditional landmark group, which was our control group, or our ultrasound guided group. And like I mentioned, that they were stable patients. We gave them a cardiac lead with the radiopaque marker tip. And so since we knew that they would get there fast and then go to CAT scan, we left these radiopaque tips on as they found where they would put their incision. And then the patient would go to CT, and this is what the image would look like on CT. So if you can see, I don't know if my arrow lines up with it, but I'll map it out in a second. But if you look to the right and the left of the patient, you can see a little radiopaque marker, and here they are right here. And so we were essentially just trying to identify a zone of safety as above or below the diaphragm. So just to reiterate, it was the residents that were assigned to these. We tried to make it as simple as possible I would run up, consent the patient, and just basically give them a tag that said landmark or ultrasound, and then the residents would perform it along with their fast. So that kind of helps to minimize interruption to the residents' clinical, wanting to move forward. So they basically just slid up from where they were. As we mentioned, so this was a convenience sample. The patients were stable. It was a heterogeneous mix of emergency department patients that came in from traumas. They did not have pneumothoraces. I don't think anybody actually ended up having one, but they could have. It wouldn't have stopped us, but they were stable. And I think that covers that. And so after that, this is my simplistic stats for you. We ultimately got 147 patients enrolled. Our power was 200 sites. So there's a very low prevalence of intra-abdominal insertions. So we had to have a higher power for this. I ended up just stopping at 147 just because I was having a hard time getting traction and buy-in anymore, even though realistically the data should have been collected within a month, just because of how much trauma we see. But you can imagine every site's a little different, and we don't have the most robust research department to help with these things. So it was kind of when I was on, this is when the data got collected. We ultimately, even though it was 147 patients, we only could identify 271 radiopaque markers. We think we lost some like if a nurse just saw a random cardiac lead, they pulled it, or it slipped off maybe from ultrasound gel. So we can't, we're speculating that those leads just didn't get on, but we did have the residents put one on each side just so we could compare right versus left as well. In this group, so there were 75 patients that were in the ultrasound group and 72 in the landmark. And then overall, we found that with the landmark, it was 88% of getting it in the correct space versus the ultrasound group, which was 97. This was statistically significant. Things we also compared with each group was their weight. So the landmark group was around 86 kilos with a 39 BMI. I think I wrote that down right. I'm sorry, 29 BMI. And then the ultrasound group was at 38 kilos with a 28 BMI. So not statistically significant difference in their weights. One other thing we did notice was the PGY 1s and 2s, we grouped them together just for more of like a power, just because there's a very few PGY 1s that did it. And we noticed the difference between the more senior level versus the junior level was, and it probably makes sense that the landmarks improved with the more senior you were. And that's likely from experience, but that's a speculation as well. There was no difference in right versus left when we compared those two. Some limitations. So if you notice this patient's how they're laying on the CT, this is the scalp film, something that we didn't take into consideration. You assume that the patient's arms were, we didn't ask the resident to move their arm when placing these markers. So in a real scenario, arm would be up over their head. And we didn't account for if the subcutaneous tissue would move. And if you can imagine, the patient has to go through the scanner, and if they don't fit with their arms down, the tech may put one arm up or both arms up. And so in this case, I don't know if it comes out clearly, on the right side of the patient, you can see that dot is actually below the diaphragm, and on the left side, it's above. And so that's another area of limitation that is there a significant excursion of that subcutaneous tissue, or is it just the one on the right was poorly placed and the one on the left was fine? So that came up in discussion. And then in reality, no chest tubes were actually placed. So, this technique, the way we did it, allowed for a lot of data points and a lot of data collection, but overall, the next step to this would be in patients that actually need a chest tube, and does it make a difference with actually inserting it? Our ultimate conclusion for me is that, for a novice learner, this may be a nice double check of yourself. Am I above the diaphragm? In patients with difficult landmarks, this could be great for any level of trainer, whether you're experienced or not. If you can't feel the landmarks, maybe it's a nice check. And if the patient has a normal anatomy, we do get an x-ray typically within 5 minutes of the patient's arrival and initial survey. So I guess you could see if there is a diaphragm out of whack, but if you're ultrasounding, which we are almost within the primary survey, you could see a difference in that diaphragm position. So our overall conclusion was this is a great adjunct. I know we get a lot of patients with a lot of lack of landmarks. So in this case, if you know where your diaphragm is, you'll feel a lot better about your zone of safety. Any questions? Hopefully I didn't go too fast.
I thought this was a fantastic example of using kind of the feasibility of current processes, like you were talking about with this is how we already do our traumas, the EFAST. Yeah. The one thing I guess I was wondering about was maybe I missed this, I apologize. Okay. Kappa values for the ultrasound faculty who read the CTs. Was that something that was included?
We didn't do a Kappa value, just seeing if we were aligned with our opinion. I guess, I don't think it's on the paper. Again, stats isn't my thing, but I know we had 2 reviewers, and then there would be a 3rd reviewer if there was disagreement, which is what you're talking about, that we didn't record. But essentially we looked at the scout films first, and then if you needed to get a little bit more granular, you can go into the CT to find it. So I don't think we published on Kappa values.
Okay.
but there's definitely, that would have been a good thing to do. This is like one of those things that I was like, this is like, I know you like need stats and data to prove your concepts in our world. I totally believe in that. It's just, it was one of those things that when we did it, we're like, this is like, just do it. It makes so much sense to like, to do it. So I encourage you guys on the next patient, even if they're normal anatomy, just go, like you're already there in the EFAS, just slide up literally 3 intercostal spaces. And you can even have the patient take a deep breath in and out and see if you see the excursion pass by. And it will shock you on some people how high, you know, you have to go. And often if I'm doing a crash line anyway, I'm sticking my fist in their armpit and putting my cut will be right below my fist. So you're up, you know, well above where you think you need to go. And this just kind of helps confirm it.
Yeah, I thought this was a really cool study. The acronym, the title of it, especially, I was impressed. No gut. I think that's a creative, not acronym. What's the word I'm looking for? Abbreviation. Or anyway. Yeah. So yeah, I also think that it's a great idea to use this. I was just doing a thoracic ultrasound on a patient earlier today who just really elevated BMI, and it is difficult to know where that diaphragm is, especially with all the tissue and everything. But I've actually, in some of the chest tubes that I've done, have just kind of, even without knowing about the study previously, like checked just to make sure where I'm going to go there's no lung sliding. I don't know if that's kind of another potential application, not only to see like, okay, check the diaphragm, but also check, okay, there's no lung sliding here, like I'm good to go in this area. I don't know what y'all think
Just
about
kind of
that.
confirming that it's a pneumo.
But yeah, I think it's super useful, especially in the patients that you have like a second to just double check and make sure that you're not going to go into the gut. No gut.
No gut. Like I said, those crash lines are just kind of like fist in the armpit, go, and you know, you don't have time. But if you have some time, just double check.
Yeah, I tend to sort of, especially if I've got the time, do the ultrasound and just sort of, you know, throw color on, just sort of make sure that the anatomy is kind of like what they teach you it's supposed to be, because there's maybe some suggestion it might not be. But it's one of these things when you mention the stats, this is kind of a little bit of a segue to the crossover design, is we don't know whether or not parachutes reduce mortality because there's never been a randomized controlled crossover study. And so, you know, every once in a while, your threshold for sort of statistical rigor has to be decreased by the fact when it's kind of the, well, duh sort of factor. And that's when, you know, you just have to apply statistics and statistical reasoning in sort of a reasonable way. But this is, you know, why ask who's on the other side of the door when you can just sort of open the little hole and look who's on the other side of the door. It's just intuitively, it makes so much sense. But it's, yeah, this is a great fun opportunistic study for sure. Yeah, it's great.
Yeah.
I would also implore though that this is also a team sport. And so if you have a research division, and if you don't, like, reach out to any of us. Like, you know, that's why I think ACEP and SAEM are here for you guys, is to provide connections, resources. Someone's probably got a statistician, you know, maybe it costs something, maybe it doesn't, maybe someone just owes someone a favor. And just being, you know, part of that community is how you can get that statistical rigor or that proofreading of the protocol or whatever you need. So I think that's just kind of like why this group exists, is one of the reasons anyway. So I would implore anyone who has those concerns to reach out.
Yeah, I definitely would have used this group if it was available at that time. Even just multi-center, like, hey, let's get a bunch of data points and really test it. But well, thank you.
Interesting, you know, the thought of, does the sub-Q tissue move? Because you're always moving the arm up when you do your thoracostomy anyway.
Mm-hmm.
So I'm not sure. That would be something to actually look at, the little subset of that. I mean, I don't know. and then, like, would it make a difference? I'm not sure, because you look anyway. But yeah, I like the concept. I also like the idea of seeing if there's actually lung sliding there, so that you know you know, if there's definitely no lung there, then you know you're going to be poking into something safe. And if there's lung there, that would definitely make me think, you know, how big is this pneumor, or is there really not a pneumor? They're just hypoxic because they have pulmonary contusions. So I thought that was an interesting addition, Mike.
Mike, that could be our next study.
Yeah.
On the real
Let's
deal.
go. I love it.
How did you get the initial buy-in from residents and people to actually do the thing if they're not being paid or otherwise incentivized? Like you said, you lost traction later on, but initially, how did you get people to actually do the work?
You know, just smiled and said, please, like, here, handed them things. And they'd be like, you know, I tried to make it as, like I said, least cumbersome to their actual like process. So they'd be doing their thing with the trauma patient. Usually for us, we have patients or residents at the airway, and then we move right around to go to the fasts next. So as soon as they were like getting their fast, I'd run to the bin and grab it and be like, landmark. So we attacked them in conference to try to get their, you know, all standardized processes. And then it was just me begging for their help, and they thankfully like me. So they did it for me. But that was it. I just had to ask and try to make it like, okay, while you're here, you know.
Did you offer any of the other services like trauma or anyone like partial authorship as kind of like a part of the buy-in, or were they not really involved?
In this case, we did. Initially, I reached out to them, trauma, to make sure that they were going to be okay with it. But since it wasn't on, like, I knew it wasn't really going to affect their patient care. Like if the person was, we wouldn't do anything to delay care. So if there was something that they wanted done, go for it. And I wouldn't do it on that patient. But then I did not push it forward to the next phase, which would have been on real trauma patients or real pneumothoraces. And in that case, I would have to get buy-in with trauma and see if they'd be willing to work with us on that. Bandwidth got low to go there, but I think we could probably revisit it.
Cool. Anything else you would have done differently? Or sorry, Sandy, go ahead.
Sometimes, has anybody tried like an incentive program for, like, you know, the resident who places the most stickers gets something, or so to help get resident buy-in to do some of these studies? Or no, it's just something that we're thinking about for a study, and I was just curious if anybody else had tried it.
That's not a bad idea.
You know, one of our faculty does that a lot, where he like incentivizes by, and I'm military, so but like if you enroll X amount of patients, he will write you an award, and then the authorship was based on how many patients you enrolled, and I thought that was very clever. I myself helped and was motivated by it.
That's a great idea to offer authorship for having done a certain number of patients. I don't know if that, I guess that technically does go into the category of like recruitment. So that's a good idea. We also have a track program here where you have to get a certain amount of track points to graduate. And if you're in the ultrasound track, we determine what creates those points. And so we use that as part of our incentive structure. I'll let you know if and when it works, because it's been on and off.
Oh, I'm curious about that. Can you send me your point structure? Because we just started an ultrasound track.
Sure thing.
Thank you.
And then Dr. Taylor, is there anything else you would have like recommend to future fellows or researchers to do either differently or thought process when they're mixing up their recipe for their next study?
Yeah, I think for me, the big barrier was, we have a pretty deep ultrasound faculty group. So like I said, it should have really been done within a month or two. And so I think for me, learning how to be a better leader in that, and just kind of like not just rely on people, but more ask, like continue, like, hey, here's, you know, maybe set some deadlines that were a little bit more concrete. And, you know, I try to get, you know, but we're getting better, but like, as far as research support, you know, I'd get like med students that would just kind of hang around to do the recruitment. So I guess it depends on what you have available at your facility. I'd say deadlines are a big thing. And then once, like, it kind of like lingered for so long that it took me just forever to, even for myself, to write the manuscript. So some of these things you can start writing the intro and the methods right away. You know, you don't have to wait to write the manuscript at the end. I'm sure, you know, you guys are learning that. So this was like one of my first big studies that I'd done. And so I learned a lot along the way of just, maybe if I had stricter deadlines, started writing the manuscript sooner, say, hey, if you want an authorship, this is what I need from you. At the time, we were very collaborative, so everybody got on everybody's paper. And so that did not help me, you know, get the buy-in I should have gotten. So we don't do that anymore. You have to put that sweat equity in. So.
Oh, yeah.
Yeah.
All right. Well, I think we're going to close that section of the appropriate the literature. We're going to move on toward our breakout rooms. So I have a total of 4 rooms currently open. If any of the rooms get really low, just feel free to either text me or send a chat message, and then we can combine rooms. But it looks like there's about 3 people per group. And if there's anything else, just let me know. Otherwise, I'm going to open up the breakout rooms. You have about 19 minutes to have your discussion, and then we'll meet back here in about 20 minutes. All right, see you in a bit.